Hi, my name is Merrina Lan. I'm a college student at Washington Lee University, and I major in biochemistry. So today I would like to read a book to you. It is called Better by Dr. Atul Gawande. So this is a book about a surgeon who is talking about the things that he thinks needs to improve in medicine and how people have been trying to improve it. For example, when people go into surgery, a lot of the times the doctors will make errors, and the patients can get infected after the surgery. So that's one of the problems he talks about, and there were of course a lot more things that went into it. So I'm reading this book because I'm interested in becoming a doctor in the future, and I want to learn more about the ups and downs of being in medicine. So I'm gonna start with part one. Chapter one is called washing hands. So it talks about if you're not washing hands enough in surgery, then there can be a lot of infections. On one ordinary December day, I took a tour of my hospital with Deborah Yonke, an infectious disease specialist, and Susan Marino, a microbiologist. They work in our hospital's infection control unit. Their full-time job, and that of 3 others in the unit, is to stop the spread of infection in the hospital. This is not flashy work, and they are not flashy people. Yonke is 45 years old, gentle-voiced and dimpled. She wears sneakers at work. Interesting. Marino is in her 50s and reserved by nature, but they have coped with influenza epidemics, fatal bacterial meningitis, and just a few months ago, a case that, according to the patient's brain biopsy results, might have been Creutzfeldt-Jakob disease, a nightmare. Not only because it is incurable and fatal, but also because the infectious agent that causes it, known as a prion, cannot be killed by the usual heat sterilization procedures. By the time the results came back, the neurosurgeon's brain biopsy instruments might have been transferred the disease to other patients, but infection control team members tracked the instrument down in time and had them chemically sterilized. Yonke and Marino have seen measles, the plague, the rabbit fever, which is caused by a bacterium that is extraordinarily contagious in hospital laboratories and feared as a bioterrorist weapon. They once investigated a nationwide recall of frozen strawberries, having traced a hepatitis A outbreak to a batch served at an ice cream social. That is very scary, don't you think? To have strawberries that are contaminated with germs and then serving them at an ice cream place. Okay, let's keep going. Recently, at large in the hospital, they told me there had been rotavirus, a Norwalk virus, several strains of Pseudomonas bacteria, a super-resistant Klebsiella, and the ubiquitous scourges of modern hospital, resistant Staphylococcus aureus and Enterococcus faecalis. Oh my gosh, those names are very hard to pronounce. I do not look forward to becoming a doctor and having to know these entire names, which are frequent causes of pneumonia, wound infections, and bloodstream infections. Each year, according to the U.S. Center of Disease Control, 2 million Americans acquire an infection while they're in the hospital. Wow, that's a very big number. I have never thought about it. 90,000 die from that infection. The hardest part of the infection controls team, Yonke says, is not coping with the variety of contagions they encounter, or the panic that sometimes occur among patients and staff. Instead, their greatest difficulty is getting clinicians like me to do one thing that consistently halts the spread of infection: wash our hands. I think this is very relevant now because during the COVID-19 pandemic, people are constantly telling us to wash our hands because it slows the spread. So this just shows that like washing our hands is a universal technique to prevent the spreading of all kinds of germs. There isn't much they haven't tried. Walking about the surgical floors where I admit my patients, Yonki and Marino showed me the admonishing signs they have posted, the sinks that they have repositioned, the new ones they have installed. They have made some sinks automated. They have bought special $5,000 precautions carts that store everything for wash-up, gloving, and gowning in one ergonomic, portable, and aesthetically pleasing package. They have given away free movie tickets to hospital units with the best compliance. They have issued hygiene report cards. Yet still, we have not mended our ways. Our hospital statistics show what studies everywhere else has shown, that we doctors and nurses wash our hands 1/3 to 1/2 as often as we're supposed to. Wow, I'm very surprised by this because in my mind, doctors and nurses, they would follow all the rules and do the best thing for their patient, but in fact, many of them aren't following the rules even when they're giving like incentives like free movie tickets. Having shaken hands with a sniffling patient, poured a sticky dressing off of someone's wound, pressed a stethoscope against a sweating chest, most of us do little more than wipe our hands on our white coat and move on to see the next patient, to scribble a note in the chart, to grab some lunch. I never thought that the white coat is used to like rub your hands. It feels almost like a white coat is like an apron. Like when my hands get dirty cutting tomatoes, I would wipe it on the apron, but I never thought doctors do that too. This is embarrassingly nothing new. In 1847, at the age of 28, a Viennese obstetrician, Ignaz Semmelweis, famously deduced that by not washing their hands constantly or well enough, doctors were themselves to blame for childbed fever. Childbed fever, as known as puerperal fever, was the leading cause of maternal death in childbirth in the era before antibiotics and before the recognition that germs are the agents of infectious disease. It is a bacterial infection, most commonly caused by Streptococcus, the same bacteria that causes strep throat, that ascends through the vagina to the uterus after childbirth. Out of the 3,000 mothers who delivered babies at the hospital where Semmelweis worked, 600 or more died of the disease every year, a horrifying 20% maternal death rate. Of mothers delivering at home, only 1% died. Wow, that's very interesting. It almost seems like it's safer to deliver a baby at home. I wonder why. Semmelweis concluded that doctors themselves were carrying the disease between patients, and he mandated that every doctor and nurse on his ward scrub with a nail brush and chlorine between patients. The puerperal death rate immediately fell to 1%. Incontrovertible proof, it would seem, that he was right. Yet elsewhere, doctors' practices did not change. Some colleagues were even offended by his claims. It was impossible to them that doctors would be killing their patients. Far from being hailed, Semmelweis was ultimately dismissed from his job. I think the doctors are acting like a little bit with ignorance here because they think that they're doing the right thing and they refuse to listen to criticism when it's like so there's so much evidence saying that doctors should be washing their hands. Semmelweis's story has come down to us as Exhibit A in the case of the obstinacy and blindness of physicians. But the story was more complicated. The trouble was partly that 19th century physicians faced multiple, seemingly equally powerful explanations for puerperal fever. There was, for example, a strong belief that miasmas in the air of hospitals were the cause, and Semmelweis strangely refused to either publish an explanation of the logic behind this theory or prove it with a convincing experiment with animals. Instead, he took the calls for proof as an personal insult and attacked his detractors viciously. "You, Herr Professor, have been a partner in this massacre," he wrote to one of University of Vienna obstetrician who questioned his theory. To a colleague in Würzburg he wrote, "Should you, Herr Hofrath, without having disproved my doctrine, continue to teach your pupils against it? I declare before God and the world that you are a murderer, and the history of childbed fever would not be unjust to you if it memorialized you as medical Nero." His own staff turned against him. In Pest, where he relocated after losing his post in Vienna, he would stand next to the sink and berate anyone who forgot to scrub his or her hands. People began to purposefully evade, sometimes even sabotage, his hand-washing regime. Semmelweis was a genius. But he was also a lunatic, and that made him a failed genius. It was another 20 years before Joseph Lister offered his clearer, more pervasive, and more respectable plea for antisepsis in surgery in the British journal Lancet. 140 years of doctors' plagues later, however, you would have to wonder whether what is needed to stop them is precisely a lunatic. Consider what Yankee and Marino are up against. No part of human skin is spared from bacteria. Bacterial counts on the hand range from 5,000 to 5 million colony-forming units per square centimeter. The hair, the underarm, the groin harbor greater concentrations. On the hand, deep skin crevices trap 10 to 20% of the flora, making removal difficult, even with scrubbing, and sterilization impossible. The worst place is under the fingernails. Hence the recent CDC guidelines requiring hospital personnel to keep their nails trimmed to less than 1/4 of an inch and remove artificial nails. I don't know how the women are going to feel about this, because I know a lot of women like having really, really long nails and put polish on them, which is very cute, but according to the CDC, these things are good places for bacteria to grow. Plain soaps do, at best, a middling job for disinfecting. Their detergents remove loose dirt and grime, but 15 seconds of washing reduces bacteria counts by only about an order of magnitude. Semmelweis recognized that ordinary soap was not enough and used a chlorine solution to achieve the disinfection. Today's antibacterial soap contain chemicals such as chlorhexidine to disrupt biomembranes and proteins. Even with the right soap, however, proper hand washing requires a strict procedure. First, you must remove your watch, rings, and other jewelry, which are notorious for trapping bacteria. Next, you wash your hands in warm tap water. Dispense the soap and lather all surfaces, including the lower 1/3 of the arm, for the full duration recommended by the manufacturer, usually 15 to 30 seconds. Rinse off for 30 seconds. Dry completely with a clean, disposable towel, then use the towel to turn the tap off. Repeat after any new contact with the patient. That sounds like a lot of effort to wash hands, so I can understand why doctors don't like to do that. Because I don't want to take off my watch when I wash my hand. It's such a nuisance, you know? Almost no one adheres to this procedure. It seems impossible. On morning rounds, our residents check in on 20 patients in an hour. The nurses in our intensive care unit typically have a similar number of contacts with patients, requiring hand washing in between. Even if you get the whole cleaning process down to a minute per patient, that's still a third of staff time spent just washing hands. Such frequent hand washing can also irritate the skin, which can produce dermatitis, which itself increases bacterial counts. Less irritating than soap, alcohol rinses and gels have been used in Europe for almost 2 decades, but for some reason, only recently caught on in the United States. They take far less time to use, only about 15 seconds or so to rub a gel over the hand and fingers and let it air dry. Dispensers can be put at bedside more easily than a sink, and at hot alcohol concentrations of 50 to 95%, they are more effective at killing organisms too. Interestingly, pure alcohol is not as effective. At least some water is required to denature microbial proteins. Still, it took Yankee over a year to get our staff to accept the 60% alcohol gel we have recently adopted. Its introduction was first blocked because of the staff's fear that it would produce noxious building air. It didn't. That next came the worry that, despite evidence to the contrary, it would be more irritating to the skin. So a product with alloy was brought in. People complained about the smell, so the alloy was taken out. Then some of the nursing staff refused to use the gel after rumors spread that it would reduce fertility. The rumors died only after infectious control circulated evidence that the alcohol is not systematically absorbed, and the hospital fertility specialist endured the use of a gel. There's so much pushback against proper cleaning technique. It is crazy to read about it. With the gel finally in wide use, the compliance rates for proper hand hygiene improved substantially, from 40% to 70%. But, and this is the most troubling finding, hospital infection rates did not drop one iota. Our 70% compliance just wasn't good enough. If 30% of the time people didn't wash their hands, that still leaves plenty of opportunities to keep transmitting infections. Indeed, the rates of resistant staphylococcus and enterococcus infections continue to rise. Yankee received the daily tabulations. I checked with her one day, not long ago, and 63 of our 700 hospital patients were colonized or infected with Mrsa, the shorthand for methicillin-resistant Staphylococcus aureus, and another 22% acquired VRE, vancomycin-resistant Enterococcus. Unfortunately, typical rates of infection for American hospitals. Rising infection rates from super-resistant bacteria have become the norm around the world. The first outbreak of VRE did not occur until 1988, when a renal dialysis unit in England became infested. By 1990, the bacteria had been carried abroad, and 4 in 1,000 American ICU patients had become infected. By 1997, a stunning 23% of ICU patients were infected. When the virus for SARS, severe acute respiratory syndrome, appeared in China in 2003 and spread within weeks to almost 10,000 people in 24 countries around the world, 10% of whom were killed. Our primary vector for transmission was the hands of healthcare workers. What will happen if, rather, when, An even more dangerous organism appears, avian flu, say, or a new, more virulent bacteria. It would be a disaster, Yonki said. Wow, this book was written more than 10 years ago, and it's asking what if a more dangerous kind of virus comes in, and I'm gonna say, well, right now the COVID virus is pretty dangerous, and I'm wondering if the doctors and nurses have been washing their hands and all of that, because it would be very sad to spread the virus within the hospital. Anything short of a Semmelweis-like obsession with hand washing had begun to seem inadequate. Yonki, Marino, and their colleagues have now resorted to doing random spot checks on the floor. On the surgical intensive care unit, they showed me what they do. They walked in unannounced. They go directly into patient rooms. They check for unattended spills, toilets that have not been cleaned, faucets that drip, empty gel dispensers, overflowing needle boxes, inadequate supplies of gloves and gowns. They check whether the nurses are wearing gloves when they handle patients' wound dressings and catheters, which are already portals for infection. And of course, they watch to see whether everyone is washing up before patient contact. Neither hesitates to confront people, though they try to be gentle about it. "Did you forget to wash your hands?" is a favorite line. Staff members have to come to recognize them. I watched a gloved and gowned nurse come out of a patient's room, pick up the patient's chart, which is not supposed to be touched by dirty hands, see Marino, and immediately stop short. "I didn't touch anything in the room. I'm clean," she blurted out. It almost seems like these two infections preventive specialists are like the policemen, they're patrolling and checking if everyone's been following the rules. I wonder if that's going to happen at my college campus this fall, because we have to take many precautions to prevent the virus from spreading. Yonki and Marino hate this aspect of their jobs. They don't want to be infection cops. It's no fun, and it's not necessarily effective either. With 12 patient floors and 4 different patient pods per floor, they can't watch the way Semmelweis did, scowling over the long sink on his unit, and they risk having the staff revolt as his staff did against them. But what other options remain? I flipped through the back issue of the Journal of Hospital Infection and Infection Control and Hospital Epidemiology, 2 leading journals in the field, and the articles are a sad litany of failed experiments to change our contaminating ways. The great hoped-for solutions had been a soap or a hand rinse that would keep skin disinfected for hours and make it easy for all of us to be good. But none has been found. The situation promoted one expert to propose, only half-jokingly, that the best approach may be to give up washing hands and get people to stop touching patients altogether. We always hope for the easy fix, the one simple change that will erase a problem in a stroke. But few things in life work this way. Instead, success requires making 1,000 small steps to go right, one after another, no slip-ups, no goofs, everyone pitching in. We are used to thinking of doctoring as a solitary intellectual task, but making medicine go right is less often like making a difficult diagnosis than making sure everyone washes their hands. It is striking to consider how different the history of operating rooms after Lister has been from that of the hospital floor after Semmelweis. In the operating room, no one pretends that even 90% compliance with scrubbing is good enough. If a single doctor or nurse failed to wash up before coming to the operating table, we are horrified, and certainly not shocked if the patient develops an infection a few days later. Since Lister, we have gone even further in our expectations. We now make sure to use sterile gloves and gowns, masks over our mouths, caps over our hair. We apply antiseptics to the patient's skin and lay down sterile drapes. We put our instrument through steam heat sterilizers, or if any are too delicate to tolerate the autoclave, through chemical sterilizers. We have reinvented almost every detail of the operating room for the sake of antiseptics. We have gone so far as to add an extra person to the team, known as the circulating nurse, whose central job is to keep the team antiseptic. Every time an unexpected instrument is needed for a patient, the team can't stand around waiting for one member to break the scrub, pull the whole thing off the shelf, wash up, and return. So the circulator was invented. Circulators get the extra sponges and instrument, handle the telephone calls, do the paperwork, get help when it's needed. And every time they do, they're not just making the case go more smoothly, they're keeping the patients uninfected. By their very existence, they make sterility a priority in every case. Stopping the epidemic spreading in our hospital is not a problem of ignorance, of not having the know-how about what to do. It is a problem of compliance, a failure of an individual to apply that know-how correctly. But achieving compliance is hard. Why, after 140 years, the meticulousness of the operating room has not spread beyond its double doors is a mystery. But the people who are most careful in the surgical theater are frequently the very ones who are less careful on the hospital ward. I know because I have realized I am one of them. I generally try to be as scrupulous about washing my hands when I'm outside of the operating room as I'm inside. And I do pretty well, if I say so myself. But then I blow it. It happens almost every day. I walk into a patient's hospital room and I'm thinking about what I have to tell him concerning his operation, or about his family who might be standing there looking worried, or about funny little jokes a resident just told me, and I completely forget about getting a squirt of that gel into my palms, no matter how many laminated reminder signs have been hung up on the walls. Sometimes I do remember, but before I can find the dispenser, the patient puts his hand out in greeting, and I think it's too strange not to go ahead and take it. On occasion, I even think, screw it, I'm late. I have to get a move on. And what difference does it really make what I do this one time? A few years ago, Paul O'Neill, the former secretary and treasurer and CEO of the aluminum giant Alcoa, agreed to take over as head of Regional Healthcare Initiative in Pittsburgh, Pennsylvania. And he made solving the problem of hospital infections one of his top priorities. To show it could be solved, he arranged for a young industrial engineer named Peter Peria to be put on a single 40-bed surgical unit at a Pittsburgh Veterans Hospital. When he met with the unit staff, a doctor who worked on the project told me, "Peter didn't ask, 'Why don't you wash your hands?' He asked, 'Why can't you?' By far the most common answer was time. So, as an engineer, he went about fixing the things that burned up the staff's time. He came up with a just-in-time supply system that kept not only gowns and gloves at the bedside, but also gates and tapes and other things the staff needed, so they didn't have to go back and forth out of the room to search for them. Rather than make everyone clean their stethoscopes, notorious carriers of infection, between patients, he arranged for each patient room to have a designated stethoscope on the wall. He helped make dozens of simplifying changes that reduced both the opportunity for spread of infection and the difficulty of staying clean. I think it is very smart to have one stethoscope for one patient in just one room. This way you don't have to carry it over the neck of the doctor and walk around and put it on different people and spreading the germ. This is such a great idea. He made each hospital room work more like an operating room, in other words. He also arranged for a nasal culture to be taken from every patient upon admission, whether the patient seemed infected or not. This way, the staff knew which patient carried resistant bacteria and could preemptively use more stringent precaution for them. Search and destroy. The strategy is sometimes called. Infection rates for Mrsa, the hospital contagion responsible for more deaths than any other, fell by almost 90%. Wow! From 4 to 6 infections per month to about that many in an entire year. 2 years later, however, despite encouragement and exhortation, the idea had spread to only one other unit in the hospital. That is strange. I thought everyone should adapt this great idea. Those other units didn't have Peria, and when he left the original unit for a different project elsewhere, performance on that unit began to slide too. O'Neill quit as head of the healthcare initiative in frustration with its lack of progress. Nothing fundamental has been changed. The belief that something could change did not die. However, John Lloyd, a surgeon who had helped Peria on the project, continued puzzled over what to do, and he happened across an article about Save a Child program to reduce malnutrition in Vietnam. The story seemed to Lloyd to have a lesson for Pittsburgh. The anti-starvation program, run by Tufts University nutritionist Jerry Sternum and his wife Monique, had given up bringing outside solutions to villages with malnourished children. Over and over, that strategy has failed. Although the know-how to reduce malnutrition was long established, methods to raise more nutritious food, more effective feeding for hungry children, most children prove reluctant to changes such fundamental matters as what they fed their children and when just outsiders say so. The Sternins therefore focused on finding solutions from insiders. They asked small groups of poor villagers to identify who among them had the best nourished children, who among them had demonstrated what the Sternins termed a positive deviance from the norm. The villagers then visited those mothers at home to see exactly what was doing. Just that was a revolutionary. The villagers discovered that there were well-nourished children among them, despite the poverty, and those children's mothers were breaking the locally accepted wisdom in all sorts of ways, feeding their children even when they had diarrhea, for example, giving them several small feedings each day rather than 1 or 2 big ones, adding sweet potato greens to the children's rice despite it is considered a low-class food, and the idea began to spread. They took hold. The program measured the results and posted them in the villages for all to see. In 2, malnutrition dropped 65 to 85% in every village the Sternins have been to. Lloyd was bitten by the positive deviance idea, the idea of building on capabilities people already have rather than telling them how they have to change. I think this is a very smart idea because I don't want people to tell me that I need to change my way of life, But if I am shown that, if you eat these kind of food, then you are healthier, then it will be easier for me to accept the practice that others have been already doing. By March 2005, he and Peria persuaded the veteran hospital leadership in Pittsburgh to try the positive deviance approach with hospital infection. Lloyd even convinced the Sternins to join in. Together, they held a series of 30-minute small group discussions with healthcare workers at every level: food service workers, janitors, nurses, doctors, patients themselves. The team began each meeting saying, in essence, "We are here because of the hospital infection problem, and we want to know what you know about how to solve it." There were no directives, no charts with what experts thought should be done. "If we had any dogmas going in," Jerry Sternin said, "it was, 'Thou shalt not try to fix anything.'" Ideas came pouring out. People told of places where hand gel dispensers were missing, ways of keeping gowns and gloves from running out of supply, nurses who always seemed able to wash their hands and even taught patients to wash their hands too. Many people said it was the first time anyone has ever asked them what to do. The norms began to shift. When 40 new hand gel dispensers arrived, staff members took charge of putting them up in the right places. Nurses who would never speak up when a doctor failed to wash his hand or her hands began to do so after learning of other nurses who did. 8 therapists who thought wearing gloves with patients was silly and persuaded by 2 of their colleagues that it was no big deal. The idea was not terribly new. After the 8th groups, we began to hear the same thing over and over again. Sternin said, "But we kept going, even if it was the group number 33 of us, because it was the first time those people had been heard. The first time they had a chance to innovate for themselves." The team made sure to publicize the ideas and the small victories on the hospital website and newsletters. The team also carried out detailed surveillance, taking nasal culture from every hospital patient upon admission and upon discharge. They posted the monthly results, unit by unit. 1 year into the experiment, and after years without widespread progress, the entire hospital saw its Mrsa wound infection rate drop to 0. Oh my gosh, that's amazing. The Robert Wood Johnson Foundation and the Jewish Healthcare Foundation recently launched a multi-million-dollar initiative to implement this approach in 10 more hospitals across the country. Lloyd cautions that it remains to be seen whether the Pittsburgh results will last. It also remains to be seen if the success can be duplicated nationally. But nothing else had worked, and this is the most fascinating idea anyone has had to solve of this problem in a century. At one point during my tour with Yonki and Marino, we walked through a regular hospital unit, and I finally began to see the word the way they do. Flowing in and out of the patient's room were physical therapists, patient care assistants, nurses, nutritionists, residents, and students. Some were good about washing, some were not. Yonki pointed out that 3 of the 8 rooms had bright yellow precaution signs because patients inside with Mrsa or VRE. Only then did I realize we were on the floor of one of my own patients. One of those signs hung on his doors. Wow. He was 62 years old and had been in the hospital for almost 3 weeks. He had arrived in shock from another hospital where an operation had gone awry. I performed an emergency splenectomy for him and then had to go back in when the bleeding didn't stop. He had an open abdominal wound and could not eat. He had to receive his nutrition intravenously. He was recovering though. 3 days after the admission, he was out of the intensive care unit. Initial surveillance cultures were completely negative for resistant organisms. New cultures 10 days after admission, however, came back positive for both Mrsa and VRE. A few days after that, he developed a fever up to 102 degrees. His blood pressure began dropping. His heart rate climbed. He was septic. His central line, his lifeline of nutrition, had to become infected, and we had to take it out. So I think at this point the patient is very likely not going to survive. But it's very sad to think that he would have survived if he didn't get the Mrsa infection inside the hospital. Until that moment, when I stood there looking at the sign on the door, it had not occurred to me that I might have given him that infection. But the truth is, I may have. One of us certainly did. I really like this doctor for being so honest and critical about himself, because I think that as a doctor, even though you have a lot of knowledge and a lot of education, you should still remain critical of yourself and constantly correct your own problems. And that is the end to chapter 1. And we will read chapter 2 again later. Thank you.